Good evening to all the aspirants present here. Good evening, Dr. Shraddha ma'am.
Good evening.
Good evening, ma'am. So, aspirants, today the topic is endocrine, and we will be having CCS session today. And our speaker for today is Dr. Shraddha Patharkar. She is an associate consultant, ABMH at Pune. Thank you, ma'am, for being with us. You can share your PPT.
Yes, I'll do that. Hello, everyone. Today's topic, though it's endocrine, most of the time CCS it goes through many different aspects and many different cases. So per se, it's not just the endocrine topic. So let's start with the case. 68-year-old, 60 kg male, known hypertensive on Telma AM, known diabetic with HbA1c of 8 on OHA, metformin, glimepiride, and dapagliflozin, and Lantus 18 units at night. He is on regular treatment, and he is known case of ISD also with ejection fraction of 35%. Post PTCS status 5 years back and on a regular anti-failure medications, SAPT and statin since then. In addictions, he's a smoker, alcoholic. He had binging just 2 days back on weekends. Recent history of obstructive uropathy, post DJ stenting 1.5 month back, and his stent is removed 4 weeks later of his admission than post his admission, and his baseline creatinine is 1.4 milligram per DL. He got admitted
Ma'am,
this time.
hello, ma'am. Ma'am, I think screen has been freezed. Can you please restart? It's not visible. It's only in one slide.
Yeah, but I'm on the first slide only.
Okay, ma'am. Ma'am, please put in the slideshow mode.
Okay. So should I present like this?
Yes, ma'am. You can. Aspirants, are the slides visible to you? Ma'am, please put in slideshow mode. It
Yeah.
will
Actually,
open.
the slideshow was only ongoing. Can you see my slides?
Ma'am, actually, it's not visible in the. Please do it in the full screen mode, please.
Yeah. This is full screen only. I'm on my screen. It's a full screen only.
Ma'am, please put in slideshow. It's near the home button.
Yeah,
Animation.
yeah. Yeah, it's slideshow only. Yeah, I'm able to see all the slides in slideshow. I don't know why that problem is there. So can you tell me? Can you see my slides?
Well, ma'am, we cannot see that in slideshow mode. It's full screen mode.
Yeah, but actually, I'm in proper slide screen mode
Yes,
only.
ma'am, it's
This is a
fine
full.
now. Thank you.
Can you see slides now? In slides, full slides. Hello.
Yes, ma'am, you can start your session. Thank you.
Yeah. So we'll start with a case. 68-year-old, 60 kg male, known hypertensive on Telma AM. He is known diabetic with HbA1c of 8 on OHA, metformin, glimepiride, and dapagliflozin. He is and Lantus 18 units at night. He is on regular medications. Known case of ISD post PTCS status 5 years back. He has an ejection fraction of 35%. on a regular anti-filler medication, single antiplatelet and statin since then. He's a smoker, alcoholic, had binging 2 days back, and he has a recent hospital admission for obstructive uropathy, for which DJ stenting was done and the stent was also removed 4 weeks later. Uh, this was done 1.5 months back. His baseline creatinine is 1.4 milligram per DL. He got admitted this time with abdominal pain, nausea, vomiting, decreased oral intake since a day. He prefers to sleep. There is a fever history since last 2 days and decreased urine output since a day as per his son. He was brought to emergency room in drowsy state, but he is arousable to deep painful stimulus. He was tachypneic, tachycardic with low BP and cold peripheries. He is saturating 90% on room air. At ER, on examination, temperature, he is febrile with 100 Fahrenheit degree temperature. Uh, his pulse is 120 per minute regular, BP 78 by 50 unsupported without any pressors, saturation 92% on 4 liter O2 by mask, respiratory rate of 35 per minute. On auscultation, there are gurgling sounds. Mentation wise, his E2 M4 VT, GCS of 8 by 15. Abdomen is soft, and on palpation on the right flank, he is grimacing. Bowel sounds are sluggish. No, there is son is telling he has not passed motion since last 2 days. Cold peripheries are there. Peripheral pulses are feeble, and left great toe amputation is noted, and it's a Hild wound. So ABG was done at ER, and the pH was 6.9, PaCO2 of 34, PaO2 of 63 on 4 liter O2, bicarb of 8, sodium of 141, potassium 6, fluoride 105, lactates of 12. Here the sugar is 250 milligram per dl. Urine ketones 3 plus. Blood ketones were also sent. So that is 6. X-ray is fairly normal, and the ECG, there is a sinus tachycardia with occasional VPCs and a QS pattern poor R-well progression as before. So can anybody just enumerate the important clinical events and history, clinical points in this case, and what are the differential diagnosis from the history and ABG?
Okay, can I speak?
I don't know.
Yeah. So can you just enumerate the salient features, whatever through the history as well as the ABG? What are the significant
So
features?
this patient, he is in shock state as his blood pressure is low. Um, 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 he has hypotension, he has fever, he has tachycardia. So this is case of septic shock. If we look to the ABGs, this patient, he has severe metabolic acidosis. He has lactic acidosis, maybe due to hyperperfusion, due to the septic shock, and also he had ketoacidosis. This ketoacidosis may be related to diabetes, as he has DKA, or due to alcohol or malnutrition. So the differential diagnosis here is septic shock plus urosepsis and DKA, lactic acidosis.
Yeah, you are absolutely correct. Its provisional diagnosis is, you can call it as a euglycemic DKA precipitated by urosepsis in patient is in septic shock. So can you just read this ABG and tell me what is the primary abnormalities, and can you read this ABG completely and
So
all
this
the abnormal values in it?
So this patient he has mixed metabolic acidosis and respiratory acidosis, as CO2 expected CO2 is really below the 34. So he has mixed metabolic and respiratory acidosis. Lactic acid is high. Ketones also is high. Um, Also, the AA gradient is high, as this patient, he is on oxygen and his PO2 just 63, so he has hypoxia. Um, What else we can say? Potassium is also 6. It's maybe due to also it's related to DKA.
So can you calculate anion gap?
Anion gap is high here. Anion gap is 141 minus 105 and chloride and 8. So it's about 20 something. Is 100
So it's
140.
around yes, it's around 28.
Yeah, 20
So it's
something.
high anion gap metabolic acidosis, and here reason might be for his high increased anion gap. It might be because of
It's
DKA.
DKA and septic.
Yes, DKA, sepsis with hypoperfusion. Uh, Patient is having urosepsis, septic shock, baseline creatinine high, so uremic lactic acidosis can also be one of the reasons. And low saturation can be because of maybe he must have aspirated or something, but the X-ray doesn't show that aspiration immediately, so the X-ray was fairly normal in the beginning. And when you calculate gap ratio, it shows normal and gap metabolic acidosis also in this case. So normally PCA2 should be low or high. So here, because of his drowsy state or maybe his respiratory muscle fatigue because of the circulatory shock, he's retaining CO2. Otherwise, to compensate for metabolic acidosis, generally CO2 should wash out. So can you just tell me differentials for this case depending upon ABG?
Sorry, differential.
Can yeah,
You mean
differential
differential
diagnosis?
diagnosis of high iron gap metabolic acidosis. This is
Yes,
what your question. It's okay. It's maybe due to shock, lactic acidosis like hypoperfusion. It could be ketoacidosis like DKA, alcoholic or
yes,
starvation. It could be acute kidney injury. It could be intoxication like aspirin intoxication, isoniazid, alcohol, ethyl glycol, methanol, toxicity.
yes, absolutely right. And because he has abdominal pain, nausea, vomiting, you can put acute pancreatitis or any acute abdominal pathologies also in differentials. So these are the differentials, and in particularly our case, the sugars they are 250 milligram per dl. So in definition of a DKA, what are the four important criteria according to American Diabetic Association to diagnose it as a DKA?
Okay, so pH less than 7.3, bicarbonate less than 18, presence of ketones, and glucose more than 250.
Yes. So in this case, this is euglycemic ketoacidosis because of
I didn't copy
yeah.
the
So
that
in
he
this
that he
case,
that
in this
he
case, the sugar is 250. So you can label it as a euglycemic ketoacidosis, though it's not completely euglycemic, but it doesn't qualify a diagnosis of DKA in terms of sugar sugar
Yeah,
criteria.
I did focus on his medication. I don't know if he is he
Yeah.
an
So
AL2 inhibitor or
yeah,
not.
the patient was on dapagliflozin. So this is the SGLT2 inhibitor that causes glycosuria, and because of that, probably his sugars are low. And second possibility might be sepsis that itself can lead to hypoglycemia. So uh, can you just tell me what labs you will do and how you will manage this case? Because it's a medical emergency, you will be doing both the things simultaneously. So how you'll approach this case?
Okay, so for the lab test, I will take CBC, kidney function test, serum electrolyte, including magnesium, phosphorus. I will take I will take also blood culture or pulse septic workup. I will go for the imaging at this patient. He is post-surgery, so I will look for a source of infection. Of course, we will start with IV fluid with a DKA protocol, normal saline between 250 to 500. I will start with the broad antibiotic for sepsis. I will also start insulin drip with zero point 0.1 unit per kg per hour. I will monitor the potassium and the other serum light here. The potassium is 6, so there is no need to keep maintenance potassium unless the potassium became low. Um, Sorry, became below 5. And here, the type of the fluid, we have to start with the dextrose saline because this patient, his glucose now is 250.
Yes, but will you start fluids first, or you'll start insulin drip first?
No, no, fluid.
Yes. So, uh, if, because see, this case, the patient is having EF of 35%, and he has underlying obstructive uropathy. Maybe he is more towards CKD side also, because of his long-standing uncontrolled diabetes, and he's currently urine output has been decreased since a day. So reason might be, and because he was having nausea and vomiting since 2 days, so he'll be volume depleted initially. So we can give fluid bolus despite his low EF as well as underlying CKD status. But you need to give fluids in aliquots rather than uh, giving 1 liter, 500 to 1 liter over 15 and 30 minutes. Rather than you need to give smaller aliquots of 300, 400 ml and see how patient respond. So here you need to utter like fluid responsiveness and initial after the initial bolus, of course. After 500 to 1 liter of a fluid, you need to reassess the fluid responsiveness using the dynamic measures of fluid responsiveness. You need to look at the 2D echo and ultrasound, and if needed, if his shock is worsening, then you might need to opt for cardiac output monitoring devices also. So first of all, so you need to categorize the patient whether it is mild, moderate, or severe decay, but because mild to moderate can be managed in HDU and ICU also. Because you need to say this patient is having severe decay, uh, you need to utter airway breathing circulation because this is GCS is 8. So these are the first uh, uh, supporting airway or protecting the airway is the first priority. Then, of course, IV fluids. First boluses, no need to check for the fluid responsiveness. You can give almost 500 to 1 liter of a fluid because he looks volume depleted clinically also. And in DK also, we have volume deficiency of 100 ml per kg. So almost for 60 kg, 6 liter. But the only thing is you cannot, like any other DK patient, you cannot give fluids blindly. You need to check the fluid responsiveness after initial first or one or two boluses. So again, the Foley's RT, wide bore IV cannula, invasive lines. You need to utter all these things. Though these are very common that we commonly do in ICU, but they are expecting you to utter all these things in exams. So, uh, can anybody tell me what will be the ventilatory management, or how you will pre-oxygenate and intubate this patient? What precautions you need to take in DKA while intubating? Uh,
This patient, he has hypotension and hypovolemia, so the risk of severe hypotension and arrest is so high. So I would like to start IV fluid to increase the volume status with standby vasopressors, and do rapid sequence intubation with medication that don't cause a hypotension like ketamine or etomidate.
Yes, but
Must
the ABG is showing CO2 retention and there is severe metabolic acidosis. You'll be, a patient will be in at least 2 to 3 minutes of apneic period, though you'll do rapid sequence intubation. You need to consider this metabolic acidosis. Patient's respiratory acidosis should not worsen, otherwise he will have severe, already pH is 6.9. If it becomes lesser than 6.8, he'll have cardiac arrest. So you need to hyperventilate this patient. You need to keep minute ventilation higher, and later on also, till the metabolic parameters settle, you need to keep uh, respiratory rate or tidal volume little on a higher side. It's better to keep respiratory rate little on a higher side, because again, lung protective ventilation, but not in initial part. Don't allow CO2 to rise, otherwise pH will fall precipitously. So is there any role of soda bicarb in this case with a pH of 6.99?
In DK, we give soda bicarb if pH is less than 6.9.
If pH is less than,
6.9.
yeah, here the pH is 6.99, and generally, if you do proper decay management with the fluids and insulin, this acidosis gets settled. And what are the disadvantage of soda bicarb? Why they have uh, put this limit of 6.9, below 6.9 only you should give? What are
Because
the side
it can
effects?
have a sodium overload also. So patient can go into hypernatremia and fluid overload, which would be detrimental in this patient already cardiac compromised. That's why
Yes, one of the reasons, but initially he is anyways volume depleted. Uh, what else? What else can happen because of soda bicarb? So soda bicarbonate, it's alkali, so it shifts your oxygen dissociation curve towards left. Already because of sepsis and because of hypoperfusion, there is at tissue level there is hypoperfusion and oxygen is anyways less. So you are hampering unloading of oxygen. It will precipitate hypoxemia and it will worsen further lactic acidosis. Soda bicarb also causes intracellular acidosis. It increases CO2. Already patient is retaining CO2. It will worsen intracellular acidosis. Soda bicarb also causes hypocalcemia. So there are very few indications where we need to give soda bicarb. In this case, because the patient is having septic shock and AKI, uh, later on you can give soda bicarb with the acid of patient's AKI is worsening towards stage 2, stage 3, and metabolic acidosis is persistent beyond 7.2. And there are other indications also soda bicarb, like if there is a TCA poisoning or if there is a salicylate poisoning. If because of this toxicities, there is a role of soda bicarb, or patient is in a pericardiac arrest situation. When you know the reason of 5H5T, the reason here might be acidosis, because that hampers cardiac contractility as well. So in those cases only you need soda bicarb, otherwise uh, it's better to avoid soda bicarb, because managing decay properly with the fluids and insulin drip, that will take care of acidosis if you are doing it properly. Okay, then here treatment of the precipitating cause. So as he rightly said, urosepsis is the precipitating cause here for the decay. And what is 1 hour sepsis bundle? What are the important components of 1 hour sepsis bundle? Can anybody tell?
Okay, measure lactic acid more than two, so we have to repeat it to make sure that there is a clearance for lactic acid. Take a blood culture, give wide spectrum antibiotic, give IV fluid 30 ml per kg of wrinkle lactate, and start vasopressors if the mean arterial pressure less than 65.
Yeah, but then you need to say this, that start vasopressors either after fluids or simultaneously with the fluids, because now there is no need to wait before starting vasopressors, like, yeah, because this patient's EF is low and already old age and CKD. So rather than giving 30 ml per kg, if your patient is not responding to first one or two boluses, it's better to start vasopressors to keep MAP of more than 65. So in when routine report came, his urine specific gravity was 1.01. Urine sugars were 4 plus, ketones 3 plus, proteins 2 plus, pus cells were plenty, and leukocyte esterase was positive and bacteria 3 plus. Can anybody interpret what this routine report suggests?
So there is glycosuria and ketonuria with proteinuria, and the bacteria are present, which means infection. And
Yes,
also, leukocyte esterase positive.
yes. So bacteria and leukocyte esterase, these are important things rather than pus cells. If the patient is already having, in this case, he was not having any catheter, urinary catheter, but if the patient underwent procedure and maybe if he's on long standing catheter, then pus cells will not uh, be that important thing to focus on, because asymptomatic bacteriuria, pyuria can be there, but here the leukocyte esterase and bacteria, they suggest, and the patient is symptomatic. Again, in our case, the flank pain, so costovertebral tenderness or the flank pain, it indicates upper urinary tract infection rather than lower. Again, that is very important to select antibiotics and to decide for the duration of antibiotic course. So what will be the next step? Anyways, I've
I'll get a CT urography done.
Yes, but right now patient is in shock. If possible, you can get CTKU be done. That is the better modality uh, for whether there is a hydronephrosis, hydroureter, obstructive pathology than ultrasound. But first you'll go for ultrasound because of his shock. Maybe he's not shiftable. So can anybody tell me what this ultrasound shows?
Air in the kidney,
So how the air looks on ultrasound?
black.
No, actually, air looks hyperdense, white. So the white part is actually air, and this this part, behind that white part, there is some shadowing, which is grayish shadowing. That again indicates air. So when there is a stone, kidney stone, this shadowing will be black, like acoustic shadowing, we say. Uh, for kidney stones, it looks black, jet black, and when it is dirty grayish, it is because of the mostly because of the air. And what other findings you notice? Size of kidney and other things.
Size of kidney is enlarged,
Yes,
and there's loss of corticomedullary
yes, very
differentiation.
good. Yes. So kidneys are bulky, enlarged kidneys with the raised echogenicity, and there is a loss of CMD, and there is a air in the renal parenchyma. So what it tells, the air in renal parenchyma means, what can be the diagnosis? What you label it as?
Emphysema pyelonephritis.
Yes, and whether any other bacterial pyelonephritis and emphysematous pyelonephritis, is there any difference?
Emphysema caused by pregnancy, most likely, right? And
Yeah, but as compared to other pyelonephritis, again, it's a very it has a poor prognosis if not, if the source control is not proper. It's a medical, again, it's a surgical emergency. You can call it as a surgical emergency. It has a poor prognosis as compared to other bacterial pyogenic pyelonephritis. So again, why CT scan is needed in this case? Because of the for the staging, because your management, surgical management, depends upon what extent this gas is there, to what extent, and to know the just not and to know the complications of his previous surgery, whether there is a collection, whether there is a source abscess, because in in those cases surgical management is very important. You need to stabilize as early as possible and get the source control. So uh, so you they will not ask this theoretical part in generally in all EDIC exams. They ask all the practical things only, but you should know various types of UTI. Even if asymptomatic bacteriuria in pregnant patients and in immunocompromised or neutropenic patients, you need to treat those patients. If in your some other, if there is a asymptomatic bacteriuria patient, you need to treat those cases. Otherwise, apart from pregnancy, neutropenia or immunosuppressed state, apart from that there is no need to treat these infections. And you need to utter complicated UTI. In our case, this emphysematous pyelonephritis, it's a renal parenchymal disease. There is a air in the kidney, so this is a complicated UTI or complicated uh, urinary tract infection, emphysematous pyelonephritis. Because why? Because your treatment, choice of antibiotics, duration of antibiotics, everything differs. So, can anybody enumerate organisms causing emphysematous pyelonephritis?
E. coli is the most common one.
Yes, any bacterial UTI or pyelonephritis for that matter, or even lower urinary tract infections, the gram-negative organisms are commonest. But here, particularly gas-forming organisms, again in that E. coli is commonest. And what else?
Klebsiella
Yes,
proteus,
yes,
monas,
very good. Proteus, and even rarely Pseudomonas aeruginosa, Enterococcus species, Citrobacter, and Candida also. If there are risk factors, like maybe patient having some is having some hematological malignancies, or patient on long-term steroids, long-term antibiotics, even they become at a high risk for fungal urinary tract infections. So, can you enumerate risk factors in this case for this emphysematous pyelonephritis, which is the commonest, one of the commonest risk factors, and also we our case have?
diabetic.
Yes, diabetes, old age, comorbidities, Apache score on admission, if severe the score, uh, female, again because of the short urethra, elderly. One more important risk factor is urinary tract obstruction. Already patient had obstructive uropathy, so because of this urinary stasis and all, they are prone to parenchymal infections. And post kidney transplant, you might get emphysematous pyelonephritis in post kidney transplant patients also as a case because of immunosuppressants. Uh, so empirical antibiotics in complicated pyelonephritis, what is the choice? Anyways, I've mentioned here in the answer. So these are the commonest. What you will choose, what you will start?
Patient is sepsis, so I will like to start with meropenem.
Yes, septic shock. So you need to utter septic shock word, because patient already on septic shock, needing high vasopressor. In management part, we have not gone through in details, but you need to utter all these things. Uh, wide bore cannula, IV fluids, hemodynamic dynamic indices of fluid resuscitation, frequent ABGs, bedside echo, ultrasound. So all these things are very important because we do for such patients we frequently do all this, but we don't utter that in exams, and they want all the common things that you do rather than theoretical part. So you need to utter as early as possible within 1 hour of admission. We know the source is urosepsis. So within 1 hour, as early as possible, we need to start antibiotics. Before that, we need to draw blood culture, urine culture. So you need to say all these things in the exams. These are very important. And then I'll start empirically with meropenem uh, to cover MDR infections because he had a recent hospitalization. If any hospitalization in recent 90 days, he underwent procedure also. He has obstructive uropathy, uncontrolled diabetes. So it's better to start with a antibiotic that will take care of multi-drug resistant organisms. So again, regarding like if you should know the MDR prevalence in your ICUs also. If patient is having COTI, catheter associated urinary tract infections, or patient develops UTI during hospital stay, nosocomial. So in such cases, you need to cover these organisms also. If your MRSA prevalence is high, then you need to cover antibiotics for that. You choose vancomycin or linezolid, but here because of the AKI, linezolid will be better choice because platelets were still okay. You need to know antibiotics that penetrate in urine. So whenever that particular case, like maybe pneumonia can precipitate decay, so you need to know antibiotics with a better penetration in lung and risk factors for this MDR infections, MRSA infections. You need to know. Again, alcohol is one of the risk factors. So, as I said, source control is very important. According to the surviving sepsis guideline in 2021, so what they mentioned regarding source control,
Should be done as soon as possible.
yes, beyond 6 hours, there is the RCTs they have shown increased mortality. So it's better to get your resuscitation and acidosis get controlled, and then as early as possible because it's a life-threatening emergency. Get source control done. So here the you cannot initially for emphysematous pyelonephritis, surgical management was nephrectomy in most of the cases. But nowadays, even for class 3A and class 3B, they go for a conservative management because they've noticed that with nephrectomy, mortality has increased. So if there is a pus collection, then percutaneous drainage. If there is a hydroureter hydronephrosis, then stenting. So all this percutaneous drainage, decompression of urinary tract, you need to utter all these words for as a source control. So in classification, class 1 and 2, again the gas in the collecting system is class 1. Class 2 is gas within renal parenchyma without extension to perirenal space. Class 3A means the gas or abscess is there in the perirenal space, and a 3B when it is in the pararenal space, so beyond Gerota sphacia. And a class 4 when there is a bilateral EPN or solitary functioning kidney. Even when there is a bilateral EPN, though it's a severe grade, because both the kidneys are involved, they don't go for nephrectomy, rather they choose percutaneous drainage or decompression. If everything fails, then the nephrectomy is the next step. Again, your viva can go to nephrectomy complications and abdominal sepsis, secondary peritonitis, etc. So, and again, in our case, I have not focused on a decay management. So, you need to know uh, when to replace potassium in decay. So, can anybody tell me when how you correct potassium? In our case, the potassium was 6. So, but otherwise, if patient comes with a potassium of 3.5 or 4, how you'll manage?
So if the potassium between 3.5 to 5.5, we have to give about 20 to 40 milliequivalent with each bag of a fluid, about 10 to 20 milliequivalent with each bag of the fluid. If the potassium less than 3.5, so we have to stop the insulin and give potassium until the potassium increase more than 3.5. And if the potassium more than 5.5, there is no need for potassium replacement.
Yeah, but you need to recheck after 2 hours, because though in decay the serum potassium is high, their intracellular stores are depleted because of osmotic diuresis. So the intracellular dehydration is also there. The stores will be depleted, uh, and once you start atrapid drip, again because of the transcellular shift, patient will have precipitous fall in potassium. So whenever the potassium is less than 3.5 in your vignette, you should utter first I'll give fluids and correct potassium, and then I will start atrapid drip. With the potassium less than 3.5, you cannot start atrapid straight away. And again for replacement of other electrolytes, like in our case ECG was showing BPCs, his magnesium was 1.8. Though there is a AKI component, you can give one bolus dose of a magnesium. For phosphate, again, uh, you need to uh, when the phosphate is less than 1, you need to replace it with, if the potassium is also less, then phos maybe. And if the patient is having respiratory dysfunction because of hypophosphatemia, and if when it is less than 1, it may cause circulatory disturbances also. So in all those cases you need to replace phosphate also, otherwise routinely you don't need to. And again, your targets for decay you should know. So what you are targeting when you are correcting, you are giving fluids and you are giving atrapid. So what you are targeting, what are your targets?
Correction the acidosis and decrease the anion gap.
No, I mean for sugar, ketones, what are your targets for acidosis? Because you cannot allow these things to drop precipitously because of this osmolar hyperglycemia. Now our case is a euglycemic, but if there is a hyperglycemic DKA, so rapid shifts in osmolarity can cause cerebral edema, especially in HHS, but it might cause in DKA also in elderly. Sorry, not elderly, in young patients. In elderly, because of atrophic brain, they will not, despite this rapid falls in sugars, they will not have cerebral edema because of the atrophic brain. They have a space to expand. But for particularly young patients, you cannot allow sugars to fall beyond 50 to 75 milligram per dl. Yes. So hourly sugar should drop 50 to 75 milligram per dl. Accordingly, you have to adjust your atrapid rate, infusion rate. And in our case, whenever there is a glycemic DKA, you have to simultaneously give D10 also. Patient is volume depleted. That's why you are giving 0.9 ns or balanced salt solution. Here the potassium was high, so we'll start with 0.9 ns. And so they might ask these questions also. Your like routine questions. What are your targets? Like reducing serum ketones by 3 millimoles. It should not be beyond 3 millimoles every hour. Your bicarbonate correction should not be. It should be at least 3 millimoles per hour. So if your sugars are not dropping and you need increasing atrapid infusion, what it indicates? The patient's sugars are not getting controlled and your requirement of atrapid is going up. Even your sodium is going up because of high sugars. They might give the scenario. Now in the next this thing, if you're giving fluids at because of the low EF, you have giving lesser fluids, 130 ml, 125 ml per hour, and your sugars are not falling every hour. There should be a drop of 50 to 75, but there is a drop of only 30, 40, and you are continuously increasing drip rate. So it indicates you are not, you are under hydrating the patient. So your sugars, when they are not dropping to the target, it means you are under hydrating. Even when ketones are not getting cleared, uh, it means you are under hydrating. You need to calculate even the corrected sodium. You need to utter all these things when sugars are once below less than 250 rather than zero point 0.9 ns. Then you, and if the resuscitation is complete, you will switch to D5 or D10. If resuscitation is not complete yet, you will give zero point 0.9 ns and give D10 also, because with atrapid you don't want hypoglycemia to occur. So simultaneously you need to supplement when once the sugars are below 250. So in our next minute, he was started on meropenem empirically. He is being mechanically ventilated. Ventilator settings adjusted according to ABG. As I said, you need to keep minute ventilation little higher till your metabolic parameter settles. He received almost 1.2 liters of 0.9 ns over last 1 hour, and the IV fluids continued at 150 ml per hour. Adrenaline infusion requirement is still high at 0.22 miles per kg per minute to maintain MAP more than 65. His last hour urine output is 30 ml, and a bedside echo lung ultrasound shows no overload signs. And his LVOT VTI is 16 centimeters. His repeat ABG after 3 hours, pH has got little better. With bicarb is still on a much lower side, bicarb of 10. Lactates are still high, 10. And his ketones have reduced to 3. Is responding to hydration, shows little element of acidosis and ketones. EF is same as before. No signs of stress cardiomyopathy and septic cardiomyopathy. See, now in this case, despite adequate resuscitation, his vasopressors are not getting tapered off, and his acidosis also not settling. Lactates are not clearing. So you need to look for some other causes. Your case might give you a screenshot of 2D echo where the EF has further gone down. So you need, and patient is in sepsis. So he might develop sepsis related septic cardiomyopathy or maybe stress cardiomyopathy. So can you differentiate between these two? What will be the echo findings in stress cardiomyopathy and septic cardiomyopathy?
EF will be low.
Yeah, it will be low in both the cases. So in stress cardiomyopathy, it has a typical pattern of apical ballooning. So there will be apical hypokinesia while the basis will be hyperkinetic. Normally, echo in septic shock patients, sepsis is a hyperdynamic state, so heart will be hyperkinetic. But when there is a stress cardiomyopathy, there will be apical hypokinesia with a basal hyperkinesia or normokinesia. And in septic cardiomyopathy, there will be global hypokinesia. They might show you clips of echo showing global hypokinesia or maybe the stress cardiomyopathy. Many a times this DKA patient can present with as a MI. MI can precipitate DKA. So your viva might go anywhere in the case. So again, if it's because of the sepsis related cardiomyopathy and lactates are not clearing, pressors are going up, you have adequately hydrated the patient, and then you need to assess the dynamic indices. If you feel on echo your VTI is still low, means your stroke volume is low and now the EF is low, it means patient is having septic cardiomyopathy. You can add dobutamine provided your MAP is more than 65, because dobutamine might again cause vasodilatation and it may cause drop in BP. So so that's why you need to utter this cardiac output monitoring We need to do you need to see the dynamic indices of the fluid responsiveness. Even in sepsis guidelines, in Albios trial, in SAFE trial, they have mentioned when you need a lot of fluids in septic shock and patient already having these risk factors also. So you can think of albumin also. In our case, we can think of albumin because there are no overload signs. But you have to be cautious because the EF is low. So you have to monitor dynamic indices and uh, plan further fluid management strategy. So this Vigilo, I don't have a photo actually, but this Vigilio monitor, which is a non-calibrated method of cardiac output measurement, it shows the cardiac output of 5.5 liter and cardiac index of 3, stroke volume of 50, stroke volume index of 25, stroke volume variation of 13, and SVRI of 1400, and the mixed central venous oxygen saturation of 70. So, what this hemodynamic data indicates? Anybody?
So SGV is a little bit high, so that means this patient may be fluid responsive. So in this patient, I'm going to give him a bolus of fluid and then measure or look for blood pressure if this patient responsive or not. If he responsive, I will continue with IV fluid. If not, I will add vasopressin.
Yes. And what else is abnormal? See, because this is
SVR is high, ma'am.
yes, same
14.
SVRI. This is not SVR. It's an index. It is index to body
Yeah.
surface area. So normal SVR is around 800 to 1400, but this is SVRI. SVRI normally it is 1800 to 2400. So this 1400 SVRI means it's a low SVRI. So it's a distributive shock. And SCVO2 of 70%. So SCVO2 is again in sepsis. It's not a very reliable parameter because of the microcirculatory failure and mitochondrial failure. They cannot utilize many a times because of this heterogeneity of the circulation. The capillaries at all the tissue levels they are not perfused, so they cannot extract oxygen, and that's why SCVO2 here 7, SCVO2 of 70. It doesn't tell you adequacy of tissue oxygenation. In such cases, actually you need to measure delta PCO2 also. So again, hemodynamic monitoring, they can your Viva can go to hemodynamic monitoring also. Again here, because patient is in septic shock, so it's a hyperdynamic state. The cardiac output should be on a higher side. With such a low, vasodilated state, cardiac output should be high. So it shows the picture of both the septic shock as well as hypovolemic shock. It's a mixed shock. So what you will do next? You said
I said
the patient looks volume
fluid,
depleted.
monitor blood pressure, and then add
Yes,
vasopressin
very good.
and hydrocortisone also stress dose.
Yes,
We
yes,
have to
because
add.
now our sugars are controlled. Your ketones are going down. Uh, and in according to new guidelines, surviving sepsis guidelines, they are recommending starting stress dose steroid once your NORAD requirement is going beyond 0.25 to 0.3 mics per kg per minute. So anyways, our patient is heading towards it. uh, so the steroids, do they have mortality benefit in
There is no
septic
there
shock?
is no mortality benefit, but this is decrease the requirement of vasopressors and also decrease the days of vasopressors, but not the mortality.
Yes, yes. So it improves hemodynamics, and basically we need to know certain trials regarding for sepsis, like for fluids. They might not ask, but sometimes once or twice the people said they have asked. But anyways, those trials, name of trials are not needed for clearing the exams. So, so can you enumerate dynamic indices of fluid responsiveness? What are the
Yes,
various?
pulse pressure variation, shock volume variation, leg rise test, IBC collapsibility, or ICB, inferior vena cava variation. Um, that's it. Yes.
Yeah, so you need to differentiate it as a you have to categorize them as invasive, minimally invasive, and non-invasive. So in invasive, you have PA catheter and pulmonary thermodilution, where you will get all the like right-sided parameters, also pulmonary capillary wedge pressure. That also helps in like cardiac filling pressures. But it's again invasive. It's again for the mixed shock, because if our case if shows cardiogenic shock also, if because of the septic cardiomyopathy patient goes into cardiogenic shock, then it's a mixed shock. So in these cases we can consider, but the Pac-Man trial, it showed it has a lesser benefit and more of a disadvantages and mortality. So we don't go for it, though it's a gold standard. And then minimally invasive being those for which the arterial line or maybe just the central line, but they need specialized tips, sometimes thermistor, and they are calibrated. So they are calibrated and non-calibrated. So calibrated means apna pico, lidco, and non-calibrated your vigilo, flow track. So you need to know about your hemodynamic monitoring, because they might ask all these questions. And in minimally invasive, at bedside you do echo and LVOT VTI. You need to know the limitations of all these modalities. What are the criteria? Like patients should be sedated, paralyzed. There should not be any arrhythmias. Tidal volume should be at least 8 ml per kg. If patient is on low tidal volume ventilation, you need to increase tidal volume. You need to do tidal volume challenge test and see the difference in stroke volume variation and pulse pressure variation. So you need to know this. Again, your Vigilo, this monitor, it's non-calibrated, and in septic shock patient, particularly when your SVR is less than 800, its patient is very much vasodilated because it is based on arterial trace. So it might not be that reliable. But when you combine clinical data, downstream parameters like lactates, ABG, acidosis, uh, capillary refill time, so all this when you combine it together, you can make out whether patient will respond to fluids, whether patient is volume depleted. So in LVOT VTI is also very important. We do that commonly at the bedside. So we give according to our this cardiac output monitoring data as well as VTI was low, so we gave some more fluids monitoring dynamic indices, and uh, we continued with hydration, either balanced salt solution or Ringer's lactate, along with D10 fluid, because see again they might show you ABG with hyperchloremic metabolic acidosis, which is a common side effect of the treatment of DK. You start with zero point 0.9 ns. Again, which is better, zero point 0.9 ns is better or balanced salt solution?
I'm not aware if there is a comparison between them, but in septic shock, yes, drinker lactate is better.
So yes, for DKA, they have said with the balanced salt solution or Ringer's lactate, the settling of acidosis is quicker. The acidosis settles uh, in a better way or quicker with the balanced salt. But overall, you have to select according to the electrolytes and the rest of the things, because if the patient is hyperchloremic, you cannot give zero point 0.9 ns. Then you have to maybe switch to 0.05 ns or those Ringer's lactate, because it has a lesser sodium. Again, you need to know about corrected sodium also. Do you know what corrected sodium is? What is the correlation with hyperglycemia? And because of hyperglycemia, uh, there is an increase in osmolarity, fluid will be drawn towards inside the blood vessel, and there will be dilutional hyponatremia. So we need to, whatever sodium is there, that hyponatremia is not the real one, it's because of the high sugar. So you need, for every 100 extra sugar or beyond 100 milligram per dl, you need to add 1.6. If the patient's sodium is 142 and if patient's sugars are 500, so 4 into 1.6, so you need to add uh, 6.4 of into that 142. So patient's sodium then goes to, actual sodium is 147, 148. In such cases, you have to be cautious with zero point 0.9 ns. Rather, you use 0.45 ns or uh, solutions with a lesser sodium. Okay, then here the again you need to continue with this hydration. Ideally, DK anion gap closes when you properly manage it. It closes by 12 hours, and ketones are the last to get cleared up. But here, because of the persistent septic shock and uremia, anion gap is still on a higher side. So you don't aim to continue this, and you don't aim for anion gap closure with your DK management because of the persistent other factors. You need to utter about even feeding, because even in European exams, they focus on other important aspects of the management in the ICU, like maybe pressure point care, physiotherapy, position change, all these things, even feeding for that matter, nutrition. Because here the patient will be on ventilator, you need to start feeds also for him, keeping check on the sugar levels. So again, hagma due to both DKA and the uremic lactic acidosis. Here it's might be because of the AKI. So again, I told about the bicarbonate. You can use bicarbonate if AKI is worsening towards stage 2 and 3. Though I have not put that in scenario, but if the patient's creatinine of 1.6, now it has, on day 2 it has become 2 or 2.2. It means patient's AKI is worsening towards stage 2 and 3, and patient's urine output is still on a lower side. It's 20 ml per hour, so he fits into the criteria for AKI definition. And then according to KDIGO, you need to know the staging. And when the metabolic acidosis is not getting corrected and the pH is persistently below 7.2, then you can think of soda bicarb. But again, it doesn't have any mortality benefit. So over next 12 hours with ongoing fluids and high vasopressors and HI drip, again his BSL continues to be between 140 to 180, ketones reduced to 2, and there is a decreasing hagma, but still there is an anion gap of 16, and persistent metabolic acidosis, still lactates are high. Again, potassium has gone up to 6. His output is 15 to 20 ml per hour over last 8 hours, and his saturation dropped to 87% with similar ventilatory settings. His peak pressures and plateau pressures on ventilator has gone up to 38 and 32 centimeters respectively. On auscultation, there are basal creps, and to maintain MAP of more than 65, now we need to add vasopressin also. Actually, we have added vasopressin much before only. So now the bedside ultrasound, echo, and chest X-ray is ordered. Can you just what can be the possibility for this current scenario? Can you?
The patient has gone to fluid overload, might be
Yes,
heart failure,
yes,
concurrent
very good.
heart failure, septic shock has got stunned cardiomyopathy leading to cardiac failure.
Okay, and this peak pressures are high, plateau pressures are high. What other diagnosis?
ARDS
Yes,
should also
very good.
be, septic shock leading to ARDS should also be kept in mind.
Okay. In ARDS, mostly it's plateau pressures that are high, but he's a smoker, so probably there is some bronchospasm also, and
So,
pneumothorax, mechanical like complications, pneumothorax also, endobronchial intubation. So whenever they give all this, you need to be very good with this mechanical issues, like maybe lung compliance, static compliance, dynamic compliance. You need to know the differentials of high peak pressures, plateau pressures, when the trans airway pressure is high, which are the conditions. So all these things you need to know. So um, these on ultrasound bilaterally you see this picture. What it indicates?
Pulmonary damage.
Yes, B lines. So B lines again rules out our pneumothorax. So bilateral B lines, it can be cardiogenic or non-cardiogenic pulmonary edema. Uh, what else? The A and B. The A is on admission. Here the VTI is 16 or 18. It's low VTI. And now the B is the current one. Here the VTI is 26. So again it indicates
Overload.
yes. Uh, what is this uh, on the right
Vexus.
side? Yes, vexus. Good. So again here the IVC is more than 2 centimeter. So we do vexus to see volume for the signs of these are the imaging for the volume overload. So you do this first graph is your flow reversal in hepatic vein. The second one is the pulsatility in portal vein, and again the third here is the renal vein. So overall picture it indicates volume overload. Even in cardiorenal syndrome, most of the times if the AKI is happening or worsening, it is because of the congestive component. So here again DD is volume overload, ARDS, cardiogenic pulmonary edema, endobronchial intubation, pneumothorax, and abdominal compartment syndrome. That can also be the possibility because patient has a infection source, though the source control was done. Clinical picture imaging again, you correctly said it's a volume overload. So daily, you need to utter these words also while managing such patients. Like we need to do daily and cumulative fluid balance monitoring because again, more than 10% of volume overload increases the mortality by 48 hours. Initial part of septic shock resuscitation is important, but you know that roads, uh, resuscitation, optimization, stabilization, and de-resuscitation. This is the fluid management in septic shock. So we whenever there is more than 10% of volume overload, it increases mortality. That's why it's important to do the cumulative fluid monitoring. So as you correctly said, volume overload, for that we have started Lasix infusion. You need to say that we will give diuretic, uh, uh, not challenge because patient is on steep vasopressors. So we are as a for a de-resuscitation we have started Lasix infusion. For again the shock was worsening and the acidosis was worsening, so we gave soda bicarb also, and because there was hyperkalemia also. ABG was repeated and the nephroreference was planned for the CRRT. You have to utter whenever volume overload. You need to utter about Lasix because the diuretics have only one role, that is in volume overload, and diuretic challenge test has a role to know whether what is the reserve of the patient, whether patient of AKI stage 1 is landing towards stage 2 and stage 3 and in future might need RRT. So apart from that, you should not give diuretics just because urine output is low. You should have signs of volume overload, or maybe for diuretic challenge in those cases only you use Lasix and congestive component of cardiorenal syndrome. So despite Lasix infusion, urine output over last 2 hours again is 15 ml per hour. Now it's almost 14-15 hours, and his output is he is oligouric. So with worsening oxygenation, high anion gap, lactic metabolic acidosis, and a patient on a high dual vasopressors, CRRT was planned. Is planned. So can you write the prescription for CRRT in this patient? Can you tell me what is the indication of CRRT in this patient first?
Volume overload with high anion gap, worsening high anion gap, metabolic acidosis,
Good.
and
Yes.
urine output is low
Yes. So why CRRT?
because patient is on dual vasopressors and
Yes.
CRRT ensures a constant hemodynamics in a unstable patient. So that's why I'll choose CRRT.
Yes. Yes. Again, other indications, if this DKA patients complicates into cerebral edema, or if because this patient is alcoholic, if liver dysfunction and because of hyperammonemia. So these are the indications you should choose CRRT over uh,
Said.
uh, hemodialysis. Even for that matter, if patient is having azotemia and hyperkalemia, will CRRT be a better option or something else?
Then hemodialysis would be better because hyperkalemia is best treated with intermittent.
Efficient treatment, because in we need if its potassium is 8 9, if patient is having heart blocks, patient is like at 9 patient will arrest, but if the patient is persistent hyperkalemia, that is causing this heart blocks and other things. But again, if the patient's pressures are quite high, you can choose sled in such cases if it's just for electrolyte imbalances, uh, because again, patient might not tolerate intermittent hemodialysis when the pressures are low. And in RCTs, they have shown no any mortality benefit or any. They have not shown CRRT is better over SLED. So, can you give prescription of CRRT for this patient?
Dose of CRRT is given by the effluent volume, which
Yeah. Effluent dose. Yes.
effluent dose. So effluent dose should be 20 to 25 mils per kg per hour. But to compensate for the downtimes in CRRT, I will choose 25 ml per kg per hour. Sorry, 25
Yes.
ml per.
Normally in uh, I mean, whatever the data we have or the trials we have, they have mentioned 25 ml per kg per hour is the dose, but to consider the downtime and here the septic shock, though in septic shock, the high volume CRRT or Plex, they don't have any role as such, but we can go keep 30 ml per kg per hour, depending upon again hypercatabolic state. If patient is like in fulminant source response because of pancreatitis or because of severe septic shock, in those cases also you need to keep effluent dose little on a higher side because of hypercatabolic state. You need to get rid of all that azotemia and everything, so you need to have a higher dose. So you are starting with 30 ml per kg per hour. Then what you'll how you'll go about, what modality you'll choose?
I will prefer CVVHDF because
Yes.
I
Yes.
have to clear the fluids also and also manage the electrolytes. So I will choose continuous venovenous hemodiafiltration.
Yes. Yes, because again, only CV, I mean, from CVV HDF, you can later on convert to CVV HD or CVVH, but it cannot be vice versa. And for septic shock also, CVV HF will be better. Okay, and then what will be the blood flow rate and
I'll
the
start
time?
100 ml per minute because the patient is hemodynamically unstable. So I'll start with 100 ml per minute. And a dialysate volume will be 10 times the blood flow. So it will be 1000 ml per hour. And pre-filter and post-filter. According to 30 mils per kg, I'll divide. Like if it is 60 kg patient, then it will be 1800 ml per hour. So I'll divide this into one thirds and two-thirds.
No, I mean, you need to see the effluent here there is a dialysate rate, there is a replacement rate, as well as the ultrafiltrate rate or the fluid removal rate. So the effluent is dose is made up of all these three. So you need to divide that as a at a dialysate and the replacement. I'll show you. So this, if the effluent dose here we are considering 30 ml per kg per hour. So you need to, if it's 1800 for 60 kg, so you need to divide it into half of the dialysate being 900 and your replacement being 900. Here again the replacement means we are not, actually it's not going into the patient. So see here again, this is we need to, because this patient is volume overloaded, we need to make this patient negative. So here, first we'll divide as a dialysate 900. We are covering 1800 by doing this, by dividing it into half. Half is dialysate, half will be the replacement, and of that half, uh, either you can keep 50-50% or 50-30, or you can keep post filter little extra, because I want to have a little higher effluent dose. So I have added extra replacement. Whenever you're increasing replacement fluid or a replacement rate, in a way you are increasing the effluent dose also, provided your hemodynamics are okay. And here my aim is to make patient negative. So my net UF will be 1.5 to 2 ml per kg per hour. So actually net UF is different than ultrafiltrate. So here, uh, either you can keep on changing replacement rate, or you can keep on changing your patient fluid removal rate. So basically, this effluent dose, it con- consists of all the three parts: the dialysate, replacement fluid, and the patient's net fluid removal. All the three. But whenever your fluid removal will be more than your replacement rate, it means you are making patient more negative. Are you getting this? And your net UF should generally, when the hemodynamics are that bad, where you need CRRT and two presses are ongoing, you cannot go beyond 2 ml per kg per hour. So how you decide about this net UF? You put that into that machine by uh, considering 24 hours, or maybe hourly. You change that hourly. So in 1 hour, if the patient is on RT feeds, on IV fluids, maybe TPM, something else is ongoing, so you consider that as a number. Let's consider that as 100. In last 1 hour with feeds and fluids, patient received 100 ml, and I want net UF of 1.5 to 2 ml per kg per hour. For 60 kg, I am expecting at least around 100 to 120 ml per hour of a fluid removal. But because I am all patient is already taking 100 ml and patient's output is just 10-20 ml, if he's having some drains, so another 20-30 ml. So in that 1 hour, 100 minus that around 30, if patient's output is 20 and drain is 10, then 100 minus 30 is 70. So patients, still the intake in is every hour is 70 ml, but I want to make patient 100 ml negative. So I have to keep net UF rate as 100 plus 70, that is 170 ml per hour. Are you understanding this? Because here the patient is volume overloaded, my target is making patient negative. So after in that 1800, I am dividing equally into dialysate and the replacement fluid. Instead of this post filter 200, you can make this pre filter 450 and post filter 450. But because I want higher effluent dose, I am making post filter. I am adding little extra at post filter also. You can do this also, and then to make patient negative or target negative balance, you are uh, you are calculating the intake and the output of the patient, and then you are adding extra uh, that much to the net UF rate that you are setting. So this is very important to you, because this patient is volume overload case. So you need to have this net UF. You need to consider this, the day hourly patient's intake minus output, and whatever that is coming. And my target is 1.5 into 60. So 90 plus whatever that intake minus output is coming, that I have to set to make patient negative. So regarding this anticoagulation, what you will choose in this case?
Renal citrate anticoagulation.
Okay, so why regional citrate?
Because citrate is the preferred over heparin. It prevents the filter clotting and
Yeah, so see, it depends. Now, patient, if the patient is having liver dysfunction, now it's because of this congestion, if his enzymes have gone up to 1200, 1400, or maybe because of alcoholism, his liver, he is having cirrhotic liver. In those cases, uh, still you can use citrate, but then you have to aim for a lesser citrate dose. Uh, you keep it less than 0.21 rather than 0.25. Or if the patient is having severe acidosis, again there is a chance that if at all the citrate toxicity happens, the acidosis might worsen. If the here the patient's platelets are okay, when the patient's platelets are low, maybe patient has developed hit because of heparin, or maybe it's sepsis induced thrombocytopenia. In those cases, depending upon coagulogram, you cannot use heparin. Then also it's better to use regional citrate anticoagulation because coagulopathy will be less. But you need to consider other parameters also. If patient is having severe hypercalcemia, you might need higher dose of citrate if there is a hypercalcemia. So that you need to decide. In our case, we can use regional citrate anticoagulation because liver functions were okay. So they again, regional citrate anticoagulation is the favorite topic. You need to know the citrate toxicity as well as the if you underdose citrate. Again, because with this regional citrate, you are using Rigoset. So regarding this blood flow, whenever you are using this, there are this preform replacement fluids for the regional citrate anticoagulation. Rigoset, uh, they do lack calcium and all in that. That is the main purpose. But again, then you cannot change blood flow rate much when you are using regional citrate anticoagulation, because again, by increasing blood flow to, you increase sometimes blood flow to reduce the filtration fraction to increase the longevity of the circuit, but in terms it will increase the citrate delivery, and uh, it will affect your target ionized calcium levels and all. So it's whenever you're using regional citrate, it's better not to change blood flow rate. Then rule of 10%. Uh, so this is if at all, see, because the ICU is such a dynamic thing. Maybe in 1 hour you have given a lot of fluids. Maybe in 1 hour patient has had some output or drains have come, has have increased. So you can change this, uh, or according to your requirement, you can change the effluent dose, you can change the dialysate or replacement fluid or net UF, but everything should be within 10% except for the regional citrate anticoagulation. With if the patient is becoming hypocalcemic, then you can reduce citrate dose even beyond 10%. But for rest of the things, to maintain the purpose of CRRT, of hemodynamic stability and osmolar stability, the fluctuation should not be beyond 10%. Uh, I think I could not explain properly, I guess, but you need to know this prescription, because in any case, if at all it goes to AKI, they will definitely ask you about CRRT prescription. And again, the pre-filter, what are the advantage of pre-filter replacement and what are the advantage of post-filter replacement? Can anybody tell me what are the advantage?
increasing pre-filter replacement will prevent filter clotting, and post-filter replacement will reduce filtration fraction.
Yes, so the pre-filter will improve the filter life at the cost of efficiency of your dialysis. So the like for azotemia or for whatever like for hyperammonemia, whatever you toxins removal, whatever you want to do, the efficiency, because it will dilute if you give pre-filter. So that you need to consider. And if it's a post filter, then of course that it will cause increase viscosity in the filter, and the filter life will decrease, the efficiency will increase, but at the cost of that. So it's better to give 50-50%, but depending upon scenario, if you feel filtration fraction is going up, you can increase pre filter. If you think patient is in hypercatabolic state and you're not able to have proper urea clearance, or you need to monitor whenever patient is on CRRT, you need to monitor Sebring coefficient, urea clearance, filtration fraction to have efficient dialysis ongoing. Because whatever you set, the prescribed and the delivered dose will not be always same. So you need to monitor all these things. Otherwise, you might set the prescribe higher dose, but the that delivery will not be that much, and the benefit of CRRT we might not have. So in day 4 ICU stay, patient on second cycle CRRT, his vasopressin got omitted. Now noradrenaline was getting tapered off. His blood cultures were negative. Urine culture flagged E. coli with the following sensitivity pattern. What it suggests and what should be the antibiotic policy and contact precaution strategy. So now the last one more slide. Can anybody tell me this? Can anybody tell about this slide? What this antibiogram shows?
So this is A. coli. So the antibiotic should be downgrade or de-escalate to one of the antibiotic that is sensitive on this biogram. If the patient on vancomycin to cover MRSA, it should be stopped. And the contact precaution is a contact precaution, like contact precautions. The patient should be kept in contact isolation, and the antibiotic should be continued until 7 days at least.
Yes, see, now this pattern is particular pattern where patient is resistant to cephalosporins but he's sensitive to capamycin, cefoxitin.
So,
Uh,
the E. coli is producing ESBLs.
yes, very good. So this is ESBL E. coli, and if at all if the patient is having bacteremia also, so with but his tapering vasopressors are tapering off. Will you choose piptas because piptas is sensitive?
No, because ESBL for meropenem should be used.
Yes, particularly for bacteremia, it's Marino trial. They have shown it is not non-inferior. Not non-inferior means it is inferior to meropenem. So it's better to use meropenem. You continue meropenem for 3-4 more days post source control. Once you control the source, you can taper off antibiotics in 7 to 10 days in complicated UTI. So for non-complicated UTI, for cystitis, even 5 days is sufficient. But for complicated UTI, you need to give antibiotics for 7 to 10 days. And regarding contact precautions to avoid spread of resistance, um, you need to isolate these patients at least for that index admission, for at least that admission. If if there is a E. coli with carbapenemase producer, in that again contact precautions will be whenever there is a carbapenemase producer, we don't have much antibiotics left, only one or two. So that's why we isolate them. They recommend it. We need to isolate them indefinitely. So it's that serious problem. Same with the MRSA, VRE. So even in this European exams, this other things like contact precautions, droplet precautions for C. diff infections, till how long you need to isolate these patients. You need to know all these things also. So not just the routine management part, but you need to focus on other aspects also. Maybe they definitely this antibiotic de-escalation. If patient is on vancomycin, so you need to stop gram-positive cover. There, here the patient did not have any risk factors for MRSA or this. Otherwise, if patient is on dialysis or a patient is IV drug abusers, or maybe patient's MRSA nasal swab, he is a carrier of MRSA or got in touch or in contact with the MRSA patient. In such cases, you need to start vancomycin empirically, and according to then culture report, you can de-escalate. So after 30 years of CRRT, after making him 3-liter negative cumulative balance, his ventilatory requirements got reduced, ABG got better, DKA resolved, and vasopressors tapering off. His urine output is still on the lower side. His son asks regarding further need for CRRT and whether he is dialysis dependent for the rest of his life. And how will you counsel his son regarding this kidney function recovery? This is the last slide. So this is the communication part. Even if you don't know things in numbers, you should know idea behind it. So can anybody tell me how you'll counsel about? He was asking whether he'll need dialysis for lifelong thing, or what will be his kidney status. He's concerned about that.
CRRT will be needed if urine output is more than 400 ml in 24 hours. So I'll calculate if it is in within 24 hours, it is more than 400 ml, then I'll continue with CRRT, or I will stop this therapy. And also I'll counsel that AKI patients, roughly 40 to 50% may develop into chronic kidney disease, which occurs after 3 months. So we will monitor the patient's kidney functions for another 3 months after discharge, and then if the patient requires dialysis or not. And
Yeah, so you were talking about renal recovery. If the patient is making urine output of 400 ml per hour in 24 hours without any diuretics, it means his kidney function has recovered.
yes,
Uh, so here the 20 ml per hour is around 400 ml per hour without any diuretic support. You need to monitor his kidney functions. You need to monitor whether his metabolic parameters, if he is still having metabolic acidosis or he relapses into it, then he might need future dialysis also. And you need even the recovery, if the patient's creatinine uh, becomes within zero point 0.3 milligram per dl of his baseline, then you label it as a recovery in terms of creatinine. Same as the AKI criteria. When his creatinine increases beyond zero point 0.3 milligram per dl in 48 hours from the baseline, then you label it as AKI. For recovery also, if his creat drops to within his baseline value within zero point 0.3 milligram per dl, so then also you label it as a recovery. But if patient's kidneys doesn't recover at the end of his ICU stay, then there is a high chance that he will land up into AKD, that is acute kidney disease, or subacute acute kidney disease. There is a 40% chance. And acute kidney disease means persistent higher creatinine than his baseline beyond zero point 0.3 for 7 days. When is persistent 7 to 28 days, then you label it as subacute AKD, and CKD is beyond 3 months. So you need to tell him he has a risk factors that he will land up into AKD or CKD. And what are the risk factors? So factors influencing recovery is baseline kidney function. He is already having underlying raised creatinine. Patient's age, he is 68. Severity of AKI, admission Apache score, comorbidity, is already diabetic, he has cardiac dysfunction. So there is a high chance he might land up to into AKD or CKD as compared to counterparts, those without these comorbidities. So you need to tell him, though his output is good, if his creat is not dropping within zero point 0.3, there is a chance that he might develop AKD or CKD, or if he develops CKD, he might need dialysis also. So, but we need to monitor him. Basically, for endocrine cases, for septic shock, for any cases for that matter, your viva can go into anything. In this case, it can go to abdominal compartment syndrome and its management, uh, even hemodynamic monitoring. Though I did not actually included images, they will put this EV 1000 images where extravascular lung water, you'll get global end diastolic volume index. You need to know the normal values of all these parameters, because These are commonly hemodynamic monitoring, and everything is commonly done in European ICUs. So even the CRRT prescription, uh, it's better you read it thoroughly, because in one or the other way, whenever AKI patient will land up into AKI, your question will, at least 1 or 2 vignettes will be there for the CRRT. Uh, for ARDS cases, there will be some vignettes on ECMO, or so you need to know these common modalities, though in many Indian ICUs they are not there, but it's very common in European ICUs. So you need to prepare that way, because even end of life care, communication, 1 minute will be on this. And now the this transplant is very much upcoming. So even the same DKA patient with emphysematous pyelonephritis in post kidney transplant recipient. So again, antimicrobial flora and everything changes. Here, you might need to start empirically antifungals also. You need to do molecular testing in such patients to get reports as early as possible. So you need to keep all these things in mind. Thank you.